Hey everyone, and welcome. Whether you're a DPT student grinding through your coursework, a resident prepping for boards, or a seasoned clinician just looking to sharpen your skills for the OCS exam, you are in the right place. Today, we are going to break down and really master the single most important skill we have in our profession, clinical reasoning. So let's get right into it. Oh man, we have all been here, right? You get that chart and you feel that little pit in your stomach. That feeling of, where do I even begin? This patient's story, it's not just some textbook case. It is a daily reality in our clinics, and it's the kind of case that really pushes the limits of our traditional thinking. This is the exact challenge we're going to tackle together today.
So, here's our game plan for this explainer. First, we'll outline the big reasoning challenge. We'll set some clear learning objectives. Then we're going to deconstruct our own decision-making process. After that, I'll introduce you to a modern reasoning framework that is a real game changer. We'll apply it all to a case study, and then we'll wrap up with 5 key takeaways you can use in the clinic tomorrow.
Okay, let's dive into Section 1, the reasoning challenge. The big question here is, why do the models we all learned in school so often leave us hanging, especially when it comes to something as complex as spinal pain?
You know, the classic model we were all taught is built on this really clean assumption. We can find one single, broken structure that's causing all the problems. But the clinical reality? Well, it's just so much messier, isn't it? We have overwhelming evidence that pathoanatomy, things like disc bulges and arthritis, is incredibly common in people with zero pain. And we know that the pain referral patterns from the disc, the facets, the SI joint, even the hip, they all overlap like crazy. So this neat, simple cause and effect model, the evidence just doesn't back it up for most of our patients with spinal pain.
And this quote from Jones and colleagues, it's absolutely fundamental. It highlights a massive evidence gap. No single classification system is perfect. And look, that's not a failure on our part, it's just the reality of what we do. What this really tells us is that mastering a flexible and robust reasoning process is way more valuable for an expert clinician than just memorizing a rigid algorithm. Okay, so that brings us to our next section, deconstructing your decisions. What we're going to do here is really dissect the mental toolkit you're using every single day. We'll look at the powerful reasoning strategies you have at your disposal, and just as importantly, the common cognitive traps that can lead us all into making errors.
So as clinicians, we're using all of these strategies a lot of the time without even thinking about it. We use narrative reasoning to really hear our patient's unique story. We use diagnostic reasoning to start forming a hypothesis. And of course, we're using interactive reasoning to build that crucial therapeutic alliance. The goal for all of us on our path to becoming experts is to move from just using these intuitively to consciously and deliberately picking the right strategy at the right time.
But here's the catch. Every single one of these strategies has potential pitfalls. Premature closure, that's when you decide it's just a disc before you've even thought about non-lumbar sources. Commission bias is that urge to do something, to add one more manual technique when really the evidence points towards just letting nature take its course with graded exposure. And a huge one is a failure of narrative reasoning, that superficial psychosocial assessment that causes us to completely miss the fear avoidance beliefs that are driving the entire problem. Just recognizing these biases is the first step toward getting better and more accurate.
So given the limits of our old models and our own cognitive biases, we obviously need a better way. And that brings us to a modern framework. This is a huge paradigm shift. We're moving away from trying to find a broken part and moving towards a hypothesis-driven, mechanism-based process.
This slide just illustrates that shift perfectly. We're moving from a simple cause and effect world to one based on probability. This is really just Bayesian reasoning in the clinic. Every piece of information we get, a positive SLR, a painful quadrant test, it doesn't give us a final diagnosis. It simply increases or decreases the probability that our main hypothesis is correct. Our goal is no longer to find a single broken structure, but to identify the dominant pain mechanism.
Now, a cornerstone of this whole framework is the symptom modification approach. This is where an intervention actually becomes part of your assessment. You apply a movement, a position, or a manual technique not as a treatment but as a test. If you see an immediate, meaningful change in their main complaint, bam, that gives you a powerful, real-time link between your exam and a targeted intervention. It's hypothesis testing at its most practical.
Okay, so this modern framework organizes pain into 3 main buckets, based on the great work of Smart and colleagues. First, you've got nociceptive pain, which is your classic tissue-based pain. Second, peripheral neuropathic pain, which is caused by a lesion or disease of a peripheral nerve. And third, nociplastic pain.
Now, this is the updated term from the IASP for what many of us learned as central sensitization. It's pain driven by changes in central processing, even when there's no ongoing tissue damage. And this right here, this is absolutely critical. These mechanisms are not mutually exclusive. A patient can have all three at once. Think of it like a Venn diagram. Our job isn't to force a patient into one neat little box. Our job is to figure out which mechanism is the dominant driver of their experience at this moment in time.
So how do we spot that dominant nociplastic mechanism? Well, the clinical picture is actually pretty distinct. We're looking for pain that seems way out of proportion to the injury. It's non-mechanical, it's unpredictable, it doesn't follow the rules. It's often diffuse, and it's strongly tied to things like high fear avoidance and other unhelpful beliefs about pain and movement.
Now, you definitely want to pay close attention to these next two numbers. This is super high yield for your exam. The sensitivity of this clinical cluster is 91.8%. So remember the mnemonic, S and out. A highly sensitive test, when it's negative, helps you rule out a condition. In this case, if a patient doesn't have this cluster of signs, you can be very confident that a dominant nociplastic mechanism is not what's going on. And even more powerfully, look at this specificity, 97.7%. For this, we use the mnemonic spin pin. A highly specific test, when it's positive, helps you rule in a condition. With a specificity this high, if your patient does present with this clinical picture, you can confidently rule in a dominant nociplastic pain mechanism. The clinical utility here is just immense. This finding should change your entire plan of care. Okay, so now it's time to apply this framework. Section 5, case study. We're going to circle all the way back to that patient from the beginning, but now we're going to approach them with this new mechanism-based lens. So here's an update from their subjective history. They tell you they have a lot of fear avoidance, and they use these key phrases like unpredictable, and it doesn't follow any rules. Does that sound familiar? It absolutely should. It maps directly onto that nocioplastic cluster we just talked about.
All right, time for a little active retrieval practice. Based on that new information, which of those three pain mechanisms should now be sitting right at the top of your hypothesis list? Go ahead and lock in your answer.
And here's the follow-up question, which is arguably even more important. If your number one hypothesis is nociplastic pain, how does that fundamentally change what you do next? What are the implications for your physical exam and for your day one treatment? Really think about that.
Let's move into our final section, the key takeaways. We're going to start by going over the answers to our retrieval questions, and then we'll summarize the 5 most critical concepts from this whole explainer.
Okay, here are the answers. For number 1, the dominant mechanism is almost certainly nocioplastic pain, given everything they told us. And for number 2, this means a traditional mechanical exam might be useless, or worse, it might even provoke their symptoms. Our focus has to pivot away from finding and fixing a structure and move towards education, reassurance, and finding ways to gently increase their function without causing a big flare-up.
All right, for your exam and for your practice, I want you to commit this 5-point checklist to memory. 1, embrace probability. Your findings shift the odds, they don't give you certainty. 2, your first job is to identify the dominant pain mechanism. 3, know that nociplastic pain clusters cold, especially its super high sensitivity and specificity. 4, be your own critic. Actively watch out for common cognitive biases. And 5, never forget that all of this expert reasoning is built on the foundation of a strong therapeutic alliance. That's how we get the good information in the first place.
So I'll leave you with one final thought to reflect on. Based on everything we just talked about, which reasoning error, maybe it's premature closure, maybe it's commission bias, which one will you consciously be on the lookout for in your own clinical practice tomorrow? Thanks so much for your time and attention.